This is Emily Horvat. Welcome back to the Expand podcast created by Respiplus. This content will bring you close to experts in the respiratory field who will be discussing the best practices with a focus on improving the lives of people living with a chronic lung condition. This podcast is part of a series that explores the journey of people suffering with chronic cough and their healthcare team. In today's episode, we'll be introducing Sara's story. Her story is particularly interesting as she herself is a respiratory therapist and was working in the asthma environment for a few years while suffering from undiagnosed chronic cough. This in itself is a testimony to the lack of awareness around this condition. We'll also be joined by Dr. Kaplan, who will comment on Sara's case. He's a family physician working in the York region of Ontario, Canada, and the chairperson of the Family Physician Airways Group of Canada. Dr. Kaplan co-chaired the Community Standards of COPD program for Health Quality Ontario, and currently still provides his expertise to a number of medical journals across the world. At the end of this episode, you'll have a better understanding of what it's like to live with a chronic cough, and we'll also have shared some lessons learned while following a thorough process for making the right diagnosis, wait times, and confounding factors.
All right, thank you very much, and welcome everyone. So I'm going to give you a brief synopsis before I start, and then we'll go through the slides if that's okay. Essentially what happened is, as a very young girl, I was repeatedly having a breathing issue of some sort. So whether it was a bronchitis or it was a whooping cough or chest infection of some sort, I always had one. Back then, because I am getting older, back then there weren't nebulizers in the home as much, so I would have to go repeatedly up to the local hospital for nebulized treatments and chest physio. At some point throughout that young time frame, they diagnosed me with asthma. And just to be clear, there were no actual formal testing done at that point. So I spent about 30 years being treated with corticosteroids and salbutamol. So I do live with my husband. We've been here for about 23 years. I am currently taking those medications, as you can see, the Tecta, because as you'll hear down the road, they thought I might have GERD, so we tried that. Hydrochlorothiazide, because I have a bit of a blood pressure issue, but nothing major. Levothyroxine, pretty basic with everybody, and Lyrica to help stop the cough when I sleep. So as far as what happens is I've been presenting with some form of chronic chest infection, acute chest infections for about the last 30 years. And in the last 15, the cough has progressively gotten worse. So it got severe enough that one day, one of the respirologists I was working with in a spirometry clinic heard it. And after I finished coming out of the bathroom with a reddened face and crying and everything else, he said, "What is that?" And I said, "That's just me. That's my chronic cough. I've had it for years, blah, 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 blah." And he decided at that point, no, that's not normal. Let's do formal spirometry. We did that. We did methacholine. And that's where we started from. And lo and behold, I don't have asthma. Changes in temperatures is one of my triggers. Strong smells, specific smells. Vanilla, the smell of vanilla makes me go into a chronic cough. And it's a pretty common smell. And stress also can make me get worse. Those are probably the big ones. But as far as other complications, as you'll hear as I go through these slides, I don't have any. So,
Sara, can I ask you a quick question about
absolutely, sure,
that you get in your throat? Would you describe it as an itch, a tickle, or something stuck which you feel as if you need to cough out? You have to get rid of it. How do you describe that feeling?
So it usually starts as a bit of a tickle and I can feel it coming on. Then it proceeds to get to the point where it's like, it feels like there's something there, and I will like do the until it comes up there. And when I say comes up, it's usually mucus, clear, sticky, white mucus. Yeah. Does that answer the question?
Yeah. And interestingly, in between these acute infections that you used to have many years ago, would you say in between those episodes you had no cough whatsoever? Or did you?
Maybe when I was maybe when I was as a young child, but in the last 15 years, it's pretty much daily that I have a chronic cough, attack or fit.
Independent of these infections that you used to get.
Absolutely.
Okay.
Absolutely. So again, I was diagnosed as having asthma when I was younger. Truly wasn't asthma. We found out later. But the doctor then sent me further to do allergy testing, immunotherapy testing. As it turns out, my allergies are cat dander and elm tree pollen. We don't have any elm trees around us, so I'm not thinking that's the issue for me. I don't have heartburn, indigestion. We did ENT. There's no polyps. It's clear. As I said, my occupation has been a respiratory therapist. I worked in home care for almost 25 years, I guess. And non-smoker, I have never smoked. I don't have a pop. You can read that. No fevers. And as far as weight loss, I don't have any major weight loss going on. Our house is completely carpet free. We have hardwood or ceramic tile, so it's not something from that. We've even changed our heating. We have no, our heating is a heat and moisture or a heat exchange. So there's no dry heat, there's no wood heat, nothing like that that's causing the issue. So basically, I don't wheeze unless I get into a coughing attack. I do exercise typically 5 days a week, either doing 3 to 5 kilometers, running or biking. So cardio wise, I don't wheeze. I also do strength training. I don't wheeze. No hospitalizations. Basically, I don't wake up anymore at night because of my lyrica. That does seem to help. But cough.
So what you're seeing, Sara, is the frustrations of people with chronic cough. I mean, you can bring it, you can hold it back for so long, but eventually you just can't. In the cortex is organ in our brain, and we can suppress some of our cough. But as Imran will tell us later, it's a disease process in itself, and he'll show us that you can't always stop it. And you can see the tickle that she had and the fact that she's coughing now. And as much as she wants to be talking to you, this is affecting her life, and she can't. And she's being treated now, right? So we'll talk about some new treatments that she's looking forward to getting on down the road. That's I just want to point out the fact that hey, this is what patients with chronic cough suffer with. So back to you, Sara.
Thank you. So it is, as Dr. Kaplan said, it does affect my daily life because we do a lot of teaching in home care. And this is what happens is I can get into a coughing fit, and especially with COVID right now, people look at you like you're, oh my God, contagious. So it's one of those things I deal with every single day. If I use an MDI, I'm typically fine. But if I use a dry powder inhaler, I'm in trouble.
Unfortunately, guys with them because they don't work and you don't have asthma. So that's just great.
Absolutely, right? Yeah. So I don't take those anymore. I haven't taken those for years now. But the cough then continues to, as you saw a little bit of it, this is nothing compared to what I normally get. It gets to the point where I cough to the point that I have major rib cage. I should have like a 6-pack and I don't. But from all that coughing, I am really working those muscles. I tend to avoid going into quiet places. Church is interesting, especially with our mask. It makes me cough typically. And as far as doing speaking, I do a lot of teaching of CPR, a lot of presentations to our patients as well as our peers. It's very hard. And most of them know me now and know me well enough. And I usually start my presentation by saying, if I start to cough, just give me 5 minutes, I'll be back, take a break. I've come to work around it because I didn't have a choice.
As you've met Sara's case here, what do you want to do next, right, as a clinician? We've done some spirometry already. Don't know if Sara said it's either reversibility or not, but let's assume there was no reversibility, so we've ruled out asthma. We've done a methacholine already. Pheno is something that you're going to hear more and more about in the next little while. It's a small little device that you blow into, and it gives you a measurement of fractionated cell nitric oxide, which is a surrogate measurement of eosinophilic inflammation in the lung. There's some rules about it, but it's actually a very simple test. It's just not covered in very many places. So most of us have not heard of that. I've actually just got a machine for my office. What about just doing a blood count? Is there anything we're going to learn from a blood count? And of course, would you like to see a chest x-ray? Someone with a chronic cough needs a chest x-ray. Don't skip that step. Don't skip that step ever. It'll come back and bite you. I was just at a program created by some of my colleagues in the UK where they talked about non-smokers with lung cancer, and it happens. So we have to be concerned. You don't want to miss that. You feel terrible if you didn't do that x-ray and miss a big proximal lung cancer because you say, well, she's too young, it couldn't possibly be her, but we see people in their 30s having lung cancer. So please don't miss that. Of course, there's all kinds of other things you can see on x-ray as well. So that chest x-ray is important. Pheno is useful because it'll tell you about eosinophilic inflammation in the lung. But again, we sort of ruled out asthma based on her spirometry. But of course, the spirometry, if it was done a day she'd just taken her medication, may not be helpful. So that may also be an issue. CBC, you're going to hear more and more about blood eosinophils over the next little while. Blood eosinophils can give you a good hint about eosinophilic airway disease. And certainly in asthmatics is a good marker of risk of exacerbations. And COPD is a good marker of the need of inhaled steroids. So that can sometimes be helpful. And that blood eosinophil count is down at the bottom of your CBC count, you look it down there, it'll say 0.3, and that'd be 300 eosinophils, which is considered significant. And of course, the chest x-ray is still first, but at some point we need to do spirometry as well. So
absolutely. So I didn't have a chest x-ray done. We went straight to the CT scan. Having said that, with the spirometry, as you said, mine came back normal. There was very limited improvement. And I do find sometimes if I'm in one of my coughing attacks, the Ventolin helps a little bit. So I always do have one on hand, just in case, but typically not that big a deal. My methacholine, like we said, was normal. We did do a lot of blood work. We did all the immunoglobulins, and I do have an IgG1 deficiency, very mild deficiency. But other than that, we didn't have a lot.
So again, Sara had mentioned they did a CT scan to rule out bronchiectasis, which is a really good thought for someone who has recurrent productive sputum and infections. That's a really good thought to think about that. Of course, if you've got bronchiectasis, then you have to explain why you have bronchiectasis. Immunoglobulin is very important. She had recurrent chest infections. If you don't think about the fact that there may be an immunologic deficiency causing those infections, you'll never make the diagnosis. And of course, an early diagnosis, obviously hers is mild, but a more significant deficiency would potentially could need immunoglobulin replacement, which then can make a huge difference for the rest of her life. So each one of these steps are really quite important. Every family doctor can diagnose like that. That's really easy. So understand that this is complicated, and you're often going to have to send people to a variety of people. Part of our job as primary care docs is going to be coordinating that, making sure the person doesn't get lost. Often spending to more than one specialist at the same time, which is not usually how we do things. But you have to rule out one thing, you have to rule out the other thing so we can get people onto the proper treatment. So with all this, we say, okay, you got asthma, treat the asthma. If it doesn't work, it's not the asthma. First step, of course, is to make a diagnosis proper of asthma. And you heard Sara say that she never actually had spirometry done in all those years. It wasn't because she was born before the advent of spirometry, it's because nobody ever actually did it. So we have to think about that. And we know from studies like Sean Aaron's work that showed, a bunch of people who were taken out of the community who were told to have asthma, and they went back and a good third of them didn't have asthma at all. And some of them had other bad conditions. But the number one predictor of them not having asthma was never having a proper diagnostic test. I know it's hard to get spirometry now. I know COVID makes it complicated, but remember, we do have to make firm diagnoses. Cough variant asthma, we use that word all the time. I don't really like it very much because I don't think it's very specific. But again, yes, we see people who cough and do respond to asthma medication. So, but again, if their spirometry tells you got asthma, then that's fine. Otherwise, they don't have cough variant asthma. Again, a firm diagnosis is everything we want to make here. Please, we need to make a diagnosis because it can save people many years. If you made a diagnosis of asthma and you're given treatment and it didn't work, then you got to do something else. If you made a diagnosis of GERD and you gave a couple months trial of PPI and it didn't work, you got to go on to something else. You can't lose these people down that endless loop of recurrent time waiting, and the patient saying, well, you didn't call me back, so I guess it's not a big deal. It is a big deal for them. And we're going to get into trials of therapy and so on for different conditions. It all makes sense. That's our life. We try therapies all the time, but we still have to have the eye on the prize at the end of the day saying, wait a minute, is this person getting better? And what am I actually diagnosed here?
That's it for today. Thank you for listening. We hope you enjoyed it and were able to get a few insights from our speakers. Make sure to subscribe to our channel so you don't miss the upcoming episodes. We'll be publishing a new podcast the first week of every month, so stay tuned. You can also follow us on various social media platforms. Just look for Expand Courses by Respiplus.